Alright, so we'll go ahead and get started. Others join in, great. If not, they can, I guess, watch the video later. So probably going to go somewhere hour and a half range maybe on talking about special populations, especially high risk OB peds, and then we'll switch gears and look at geriatrics and kind of the differences and the consideration in transport. And there's not a whole lot of difference, especially in the geriatric population. There's maybe some different ways you may focus and think about your transport. Same goes with OB and peds, and as we'll talk about, especially with peds, there's entire courses on critical care for pediatric patients. There's specialty teams. So if that's the population that you're looking to serve or be a part of one of those specialty teams, then eventually you would want to take those specialty type certifications and exams such as the CNPT exam and get something that is geared and focused directly toward pediatrics, their conditions, the congenital birth defects that are common, usually involving heart, lungs, or GI tract is where you see those manifest. But in any case, this is just kind of a high-level overview of transport considerations, and then an intro to resuscitation, and you would need to get more detailed into the other. So when we start out talking about the OB, and we're going to move from OB through delivery to into the pediatrics, kind of progress in a logical order. So starting out objective-wise, we'll talk about the physiologic changes of pregnancy, pre-existing conditions, patho, and then the transfer and equipment. So presentation is titled What's Normal, What's Abnormal. So what's normal? We know that the body's still going to experience change from the pregnancy. If nothing else, the fetus is going to take up additional space and restrict movement of various organs, including diaphragm, lungs. So respirations are going to be affected. Late pregnancy pushes the diaphragm up, the ribs flare outward, the thorax increases in size, and thus lungs are compressed. Our patients that are pregnant have an increased oxygen need. It increases by 15 to 25%, their minute volume up by 40 to 50%, which relates then to their tidal volume, and something that would need to be considered in setting in events. Their PCO2 decreases to 2832 millimeters of mercury, so that's a slight change that you would keep in mind either in evaluating an end-tidal or a lab value, and realize that theirs would naturally be a lower PCO2 reading. And then PO2 jumps to 101 to 108, so just a little bit higher than what we would normally expect. But then again, we have to remember that when we evaluate lab values and realize that roughly about around a 10-point difference there. Well, we normally shoot for the 100 mark, so they could be 108, which means if they're now at 90, they're really significantly more hypoxic than what we would expect in a normal patient. So keeping in mind the little bit of difference there, and they're really living in a compensated hyperventilation type state. So cardiovascularly, what changes? It becomes a high flow, low resistance environment. The volume jumps up to 20, 25% by the end of the first trimester, and they have an increase in plasma and red blood cells while the hematocrit decreases. Their cardiac output goes up as well. You have a volume increase. You should also have the associated output increase to 30 to 40%. Their CVP, or that central venous pressure, is going to drop from around 9 to 4. Heart rate should speed up around 10 to 15 beats per minute. Again, something we have to keep in mind when we're evaluating vital signs that they should be a more elevated heart rate, and that if we look at their heart rate in comparison to, say, yesterday with considering a trauma patient, if their heart rate is low, they may not be compensating as well as what we would expect in a normal patient. If their heart rate is higher, we have to keep in mind that that may not be a sign of a hypovolemic shock that they're trying to compensate. That may be a normal finding depending on what range it's in. So you have to keep in mind, again, kind of like the labs, there's a little bit of difference that you would expect in their heart rate, and then as well in the systolic and diastolic blood pressures, that's a little bit lower. The heart is also displaced up and to the left, and a slight rotation to the front, which could create a possible axis deviation on your 12 lead that you would detect. And also, thinking back again to yesterday in the trauma patient, if we do a fast exam and we're looking for a fluid in and around the heart with that EFAST, then we may have to change our positioning a little bit there as well, as you know, the heart has also changed where it's normally seated in the pulmonic systolic and apical systolic murmurs would be a normal finding, and you'll see it mentioned several times. Have to be careful for a supine hypotensive syndrome, and watching how we position or place our patients for transfer because of that. Placental blood flow is very sensitive to maternal blood flow and shock. Of course, the mom's body is going to do what it can to preserve itself, and so anything that's impacting their blood flow is first going to impact that placental blood flow. From a perspective of the endocrine system, they have high progesterone and estrogen levels, so going to see an increase in hormones there. Going to have a state usually of hyperglycemia. The thyroid is going to enlarge, and the pituitary gland is going to be anywhere from 30 to 100% larger, which makes it subject to injury during shock, also known as a Sheehan syndrome. Hematologically, white blood cell count is going to be up. You're going to have an increase in those clotting factors, the 7, 8, 9, 10, 12, and so that's going to make the blood more coagulable than normal. And the lab readings, they say here, can be kind of misleading and lead you on a path of thinking the patient's in a state of DIC, which we hit on yesterday, talking about the both clotting and hemorrhaging at the same time in that trauma patient. So that disseminated intravascular coagulation, DIC, be careful in interpreting the labs and thinking that's the pathway for the OB patient when that's possibly a normal finding. When we look to the GI, the genitourinary system, find that they're high risk for aspiration. Think about the fact that there's now a fetus sitting in the abdomen, crunching up space, so there's going to be a decrease in GI motility, delayed emptying, soft tissue changes face and neck. There may be some additional swelling, edema, that kind of thing there, and just the change in body shape and size and trying to position that OB patient is going to make it one of the more difficult intubations. And so it's one of the things in evaluating an airway, most of your moans and lemons and other acronyms consider the OB patient as part of a difficult intubation pathway. The ureter and kidney end up dilating, but bladder emptying may be delayed, which increases a risk for bacterial growth, and thus from that then an infection. Renal blood flow is going to increase anywhere from, as you see there, 25 to 50%. When we look at the reproductive system, the combined weight added to our OB patient of uterus, fetus, placenta, and fluid at term is about 4,500 grams or 4.5 kilos there. So there's also going to be an increased blood flow to the area, and the uterus, which can hold an extra 2,000 mLs or 2 liters of blood without any outward signs. So you have to think about that in your OB complications and in potentially a OB trauma patient, kind of like how we're usually concerned with how much blood can be held in the pelvis. The uterus can hold their 2 liters. And in the third trimester, the uterus wall is pretty thin and unprotected. So, especially again with trauma, it would be subject to an ease of rupture. Placenta at maximum vasodilation and is very sensitive to catecholamine stimulation. So that's kind of the bit of what's normal, what's some abnormal findings in comparison to how we would approach or look at the normal patient versus the now pregnant patient that we're called to transfer. And these are not all that uncommon. It depends the system you work for. Ours has a separate women's hospital that is outside the regular hospital. No matter how many times they advertise it, people still go to the wrong place. They end up showing up at the main hospital for OB-related complications or in labor or imminent delivery and need transfer. They also are patients that receive specialty care at Chapel Hill or Duke or other locations that know they have a complicated pregnancy. During prenatal care, there's been complications with the child that have been identified that require immediate specialty care after birth. And though these people and patients know that they need to be at Chapel Hill or Duke when the time comes, things happen, they're visiting family and go into labor early, or they are living in your area and they have a planned delivery date and time and are going to be induced, and nature takes hold early and they're not in the location they need to be, and so you'll get a lot more of the calls, I think, for OB patients to be transferred to specialty facilities than you will the pediatric type patients. And it's just one of those things that happens. And you've got to kind of know the difference, as well as then think about what the differences are in assessment. We already hit on with the supine hypotensive syndrome to consider your patient's positioning and their comfort in how they're positioned. Often, it's pretty easy. They're not a difficult patient there to deal with. They know what's comfortable for them, what works best, what keeps them from getting lightheaded. They'll pretty much position themselves in a position of comfort, and you're just trying to help them with your equipment, your stretcher, the safety needs of getting seat belts and that kind of thing, for the stretcher strap belts onto them, and getting them comfortable on a smaller surface than probably the large hospital bed that you're taking them from. So you have to think about positioning. Then we have a separate special tab for a obstetric history, and these are the important things that you want to assess and know about the OB patient, and that you want to document to get a good clinical picture of the patient, as well as then being able to plan for your transport, know what to expect, know is this going to be a pretty easy, straightforward transfer, or is there risk of delivery en route, or complications, or patient becoming unstable. So first off, the due date. When is the expected date of delivery for the child? If they know that, some will not, because they come in and this is the first time they find out that they're pregnant, and they're pretty far along in the process, and it's more of a rush to get transferred to another facility, and they haven't gotten all their information yet. But most, if they've had normal, adequate prenatal care, be able to give you the due date. If you ask the last menstrual period, that will give you some idea of what to expect for a due date. In those that do not yet have that information because of a absence of prenatal care, you can get some idea of where you're at time frame wise, finding out what the last menstrual period was, their para and gravida, how many times they've been pregnant, and now how many have they delivered. We all know from field EMS what that gives us. We hope to have the first time pregnant and never delivered mom, because we know if labor's just started, we've probably got time. Always exceptions to those rules, but we kind of relax a little bit and think, okay, this isn't going to be rushed. We've got some time to deal with things. We get one that's been pregnant multiple times and delivered 7 kids, and it's time for a little bit more of a poker factor, because this ain't going to take it long. Then you want to know known complications. Have they been told they have a complicated pregnancy or delivery? Have they been to the doctor recently and know there is some type of congenital defect with the child that needs to be addressed? Do they know the child is breech? Do they have some kind of medical condition that may complicate the pregnancy from the mom's aspect? Are they one that developed hypertension or diabetes during their pregnancy? You know, sickle cell disorder, anything that may complicate the care of the mom or newborn during and after delivery. So any known complications. And again, those would come into play a lot of times when you're transferring these patients to facilities for higher levels of care. Transferred one, it's been several years back, but she was one that she was in our area visiting family, had been going to Duke, had plans to deliver at Duke. The doctor at Duke had told her there was a issue with the cardiovascular system of the child. I don't remember exactly what the condition was, but basically she had to deliver at Duke and the child go straight to surgery to have a chance to survive. And she started and went into labor in our area. Luckily, she did make it through the transfer. She made it to Duke for them to then manage that delivery. Didn't hear an outcome ever of how her or the child did, but at least on our part, she got where she needed to be to deliver, to have the specialist to then provide for the child as it needed. So, are there some known complications? And then, what kind of prenatal care have they had? You'll have everything from absolutely no prenatal care, did not know they were pregnant, and it just found out as they're ready to deliver to they completely bypassed prenatal care. They knew they were pregnant. They just were non-compliant with going, or they went hit or miss randomly. You know, they went once when they first found out, they went back at 3 months. They're now at, 8, and they haven't been in 5 months, to some that are strictly compliant with the prenatal care and the appointments and know every bit of information related to the pregnancy. And finally, any previous complications. So, if they're one that has been pregnant before or pregnant and delivered, what happened in those pregnancies? Was it a normal delivery? Were there difficulties? Were there problems with the child? Did the mom experience problems? Finding out what's went on before. Once you get that picture with the history of the patient, then you can look to some of the assessment tools outside of what we would get on pretty much any patient, vitals, labs, that information out of the report, but then look to fetal heart rate monitoring. You'll see this in the facility, actually attached as a probe typically to mom's stomach. One of the first things you want to document is where on the abdomen that probe is located and picking up that fetal heart rate, so then you know where to go back and find it. And it may be, to the right, to the left, at the umbilicus, but wherever that is working. And so then look to the fetal heart rate monitor itself to find the rate, and has that rate been fairly consistent, and is it in a range of a good fetal heart rate? If there's concerns over fetal heart rate, that's one of the things that should be addressed before you take off bouncing down the road and are off on your own with just you and your partner handling mom and this infant. Once you're out of the facility, if you have the capability, the measurement of fetal heart rate will rely then on being able to Doppler it. We carry the little handheld Dopplers and battery operated in our trucks so that we can do that. And that's again why you would want to note that location, because it's not then attached like the continuous fetal heart rate monitoring in the facility is. So you would have to take out the Doppler, use jail, and go back to wherever they were at locating that fetal heart rate and then count it from there. And depending on your leak to transfer, you would want to Doppler and record that fetal heart rate 2 or 3 times, kind of with the normal vital signs you would do with mom. And then finally there, document, mom's noting movement of the fetus. She feel the normal kicks and turns and everything, or has it been a while, or, is it about the normal amount of activity that she feels from the fetus. And again, document that I would at the start and then toward the end of your transfer, noting any changes there. And here you see the fetal heart rate monitor to the left prints out the strips, looks very similar to EKG. Of course, the Doppler is going to be a smaller handheld device that doesn't print out a strip like that. So you want to make sure, again, you know where to place your Doppler to pick up that fetal heart rate. You can see here actually the image at top rather than showing the external probe that straps onto mom's stomach. They're showing the placement of the scalp probe. You see that less often, but if they have placed the scalp electrode, then I would take the time before I leave out to go ahead and get the Doppler, locate the fetal heart rate before they disconnect from that scalp probe. And again, you can notate your location at that time, notate that, what you found Doppler does correlate to what they're showing on the fetal heart rate monitor, so you're at the right place. You're picking up the fetal heart rate definitely, because the two coincide, and then allow them to disconnect that electrode for transfer and proceed on. And then at the bottom right, they're showing you different fetal heart monitor patterns, whether it's early or late decels, or an elevated heart rate, or more of the normal pattern. Those you get very detailed in how they're interpreted. If, again, PEDS is something, and high risk PEDS and OBs that you want to get into and transfer, then this would be something you would want to study. It is part of those exams, but it's not something that, I know what I'm looking at and what it relates to, but it's not something that at this point I would sign up to teach a class on how to interpret the fetal heart rate strips. So just know that that is a component should you want to get further into this topic or transport specialty. Your pre-existing conditions that are related with pregnancy and how they kind of impact things for mom and then fetus. They say there's two ways that pregnant patients find themselves in an ICU. They have some type of previous condition that the pregnancy makes things worse for mom. And I think in a slide or two you see a discussion of like asthma and how some people get better, some people get worse, some people stay the same. So often it's kind of hard to predict how pregnancy is going to affect mom's pre-existing conditions that she kind of brings into the pregnancy with her. So if things go rough for mom, then those pre-existing conditions can end up bringing her into a ICU needing care and subsequently probably transfer to a location if she doesn't find herself in one initially, us transferring her to a location that can deal with both her medical needs as well as the fetal needs and planning for a more complicated delivery and managing all those aspects together in one location. Or the second way to end up in an ICU is the normal pregnancy itself gets complicated. Mom was fine, she was healthy, but now there's either impacts to her health that are brought on by the pregnancy, there's problems with the fetus, there's expected problems with the delivery, something of that nature. So with pre-existing conditions, it's all the things we normally think of: heart disease, valve disease, Marfan syndrome, hypertension related issues, asthma, back up above valve disease, I think I skipped over the coronary, and heart related diseases. The asthma, back then, has the 1/3 rule. Some there's no change, some improve, some get worse. And seizure disorders and how to manage seizures if that is a common finding in mom. Unfortunately, we find many that wind up in facilities or wind up in transports that are pregnant and also have a substance abuse problem. They're not able to or have not been able to get off whatever the drug of choice is. They've not successfully made it through any kind of rehab program. And now that poses risk to both mom and baby. And of course, STDs, HIV, diabetes, sickle cell, a risk there of urosepsis, and we talked about yesterday how sepsis affects the body, especially in its progression if we don't intervene and try to stop that early. Our complications of pregnancy are, again, when a healthy OB patient gets complicated. There may be a cardiomyopathy. The patient doesn't have any evidence of heart disease prior to the pregnancy, but now around the 9th month through 6 months postpartum, they find themselves with symptoms of CHF, and that congestive heart failure can have a mortality as high as 50%. AMI, outcome again related to timing of when that cardiac event occurs. So it says here, if that cardiac event occurs closer to delivery, there's a higher chance of mortality. And then in shock or trauma. We see issues with lactate levels, which would be, again, indicative of more of a Sears, I guess, pathway in that case, or that systemic inflammatory response, because although it's roughly the same as we talked about yesterday with sepsis, we don't have that infectious agent. So rather than call it sepsis, we call it SIRS or Sears, that systemic inflammatory response, but still the same path. Or then finding a lab test showing fetal cells in the blood. When we start to look at hypertension, there's various levels from the hypertension up to the toxemia of pregnancy, and we've all had some exposure to that through initial paramedic courses, but pregnancy-induced hypertension could be that they come in hypertensive. People are out there suffering from that, but it kind of, again, depends how compliant that patient is with treating the hypertension before they become pregnant, and how they continue to manage that once they are pregnant, versus also the patient that comes into the pregnancy perfectly healthy, has never had any history of hypertension, and now the pregnancy itself induces it. Then if we start to see signs of that proteinuria after roughly 20 weeks there of gestation, along with the hypertension that was induced through the pregnancy, we consider it a toxemia. And then toxemia with the hypertension that is a chronic, but then a sudden onset of it despite the care, throws us into a preeclampsia situation, and then eclampsia once seizures begin to occur. And even with this, you don't always get warning of what is actually occurring, or that this is what is truly going on in your patient. And sometimes, not knowing, you're left playing a guessing game. I was part of, I guess we ended up with 3 teams called to transfer a patient. County EMS was bringing in a patient that they thought was in a hypertensive crisis. They called her, she didn't feel good. They get there, find her blood pressure through the roof. The patient was a larger female, so the aspect of being able to see or note that she was pregnant was not there. So she just looked like her size normally. And so they transferred her to a hospital that was appropriate for her, but not appropriate for the delivery or management of a child. And with her size, not knowing she was pregnant, she had no idea she was pregnant. They thought she was just simply a hypertensive crisis. They treated her for that, transferred her. As they were pulling into the ED, she started to seize. She ended up going into arrest for just a couple of minutes before they were able to resuscitate. They got her somewhat stabilized and into the ED. When the ED examined her, they found that she was pregnant, decided to go straight to surgery there. They didn't really have much other choice, so they had to do the C-section there to go ahead and try to save the infant and save mom, and had called us to standby because initially they call for two, one to transfer mom, one to transfer the infant. We'll talk about those transfer and transport considerations and options shortly. But once they got into surgery, they went to take the infant through the C-section and went, oh crap, there's not one, there's two. So suddenly became three patients out of what initially thought was a hypertensive crisis that ended up being truly eclampsia with mom seizing and then subsequently having to go through the emergency C-section, transfer both mom and now two infants to appropriate care centers. With preeclampsia and pregnancy-induced hypertension, your risk factors there include African American, multiple gestation, teens, diabetics, and a female over 35 years old. With preeclampsia, you're looking at hypertension, proteinuria, and edema. The system, when they go into preeclampsia, goes from a high flow, low resistance cardiovascular system to now high resistance and low output. So everything kind of flip-flops. There's reduced vasospasm, and so you want to keep the diastolic pressure below 90. And corticosteroids may be something that they order late to mature fetal lungs if OB is going to be induced or sections. So in that patient I was just talking about transferring, had they known ahead that she was pregnant, had she had prenatal care, known that she was in a preeclamptic state and likely to have to either be scheduled for an induction or C-section, then that may have been something her obstetrician would have ordered us to go ahead and begin corticosteroids to help make sure those lungs are in a better condition and make the fetus more viable. Eclampsia occurs with diminished LOC or seizure after 24 weeks to in the range of 1 to 2 weeks postpartum. So it's one of those progressive things, kind of like SIRS leading to MODS yesterday, preeclampsia to eclampsia. You hit eclampsia once you decrease LOC or begin to suffer seizures. But again, we have to differentiate between eclamptic seizures and knowing the history of our patient if we can to decide, did they have a pre-existing seizure disorder. They're going to treat with mag sulfate, which, it's not a complicated thing to manage on the drip. You just have to watch for a toxicity. And mag, they're going to usually infuse, ours usually go with the 4 grams. Here it says 4 to 6 over 10 to 30 minutes, and then infuse 2 to 3 grams an hour. Ours is usually the lower end of that. They infuse 4 grams and then the maintenance drip at 2 grams an hour. Control against seizures with benzos if necessary, but whatever it takes, we want to stop and then prevent further seizures. Your mag sulfate, when you look toward toxicity, for seizure control in the preeclamptic or eclamptic patient, that 4 to 6 grams, then the 2-hour infusion, or 2 to 3 gram per hour infusion. Things to look for in toxicity: hypertension, respiratory depression, a heart block developing, or depressed reflexes. What you'll see if you take a certification exam, the key question there is, what's the sign of a magnesium toxicity? And it's going to be looking for the loss of and the way they phrase it on exams, the loss of deep tendon reflexes. So rather than depressed neuroreflexes, as this says, you'll see on exams, loss of deep tendon reflex. And the treatment then for a magnesium toxicity is ventilatory support, and then treat them with calcium IV. Either most people carry the calcium chloride, some calcium gluconate. Usually it's chloride because it's cheaper. If we continue looking at complications, you find the HELLP syndrome, hemolysis, elevated liver enzymes, low platelet count syndrome. It occurs either with the pregnancy-induced hypertension or with preeclampsia. 12% of women with the pregnancy-induced hypertension are at risk. And this usually presents with telltale signs of right upper quadrant pain, malaise, severe edema, signs of preeclampsia with labs showing that red blood cells have hemolyzed, thrombocytopenia, and elevated liver enzymes. Most of the time, your test will ask about HELLP syndrome, and what you should key in on in that is they're asking about a pregnant patient, and look for a pregnant patient that has signs of preeclampsia with additional symptoms that, easiest way to remember it, additional symptoms that don't match preeclampsia. So find your preeclamptic patient and find additional unmatching symptoms, and you've got your answer. So it will be those, a lot of times they'll throw in the preeclamptic patient with like right upper quadrant pain, abnormal RBC lab, and either elevated liver enzymes, or they'll say they note a thrombocytopenia, and that will be again tied to your health. And treatment, medical ICU, hemodynamic monitoring. Just like eclamptic or preeclamptic, they're going to prevent seizures and control the hypertension. Respiratory, covered it yesterday with more of an in-depth discussion of ARDS, but this can occur as well in the pregnant patient, secondary to sepsis, to tocolytic administration or AFE, which we'll see more about in a second. And as well, trauma or any other septic process that they become involved in. A PE, standard treatment, but can't give warfarin. And then your AFE, an anaphylactoid syndrome, is what it is noted as. Immediate postpartum PE with fever, and that coming from a fetal tissue antigen, and this is about 70% fatal. As far as knowing that, never really seen it pop up on a test or heard.
Wait, what is SX?
Do what?
What is SX?
Where you see it?
Sign, symptom.
Okay, thank you.
No problem.
Oh, okay.
Then trauma and pregnancy. Remember your positioning, that's supine hypotensive syndrome. Try to find out what gestational age you're dealing with. Remember the placenta's sensitive to shock, and in that case, the body's going to consider the uterus a second organ. So, it's going to do what it can to focus on and say, Mom, we have to, again, fall into a triage role here. especially when we find out that gestational fetal age, is this going to be a viable second patient if delivered, or is that something that is not going to be possible? We focus our self straight to mom, and the body, unfortunately, whether fetus is viable or not, will quickly, if it has to, empty the contents of the uterus to save mom. Placental disruption, I would review these, especially if you're going to take an exam. The placental abruption versus placenta previa, and which ones are associated with, such as abruption pain and may or may not see blood, versus previa, which is painless bleeding. And that's usually what kind of question you'll see is which one has blood and no pain and which one has blood and is painful. And so know the difference there. Abruption is going to be painful. Placenta previa, usually not. But also, as we hit on and talked about yesterday, still have the DIC, disseminated intravascular coagulation. You can have a patient with a dead fetus syndrome, the gradual onset of this DIC caused by the fetal demise, 80% with spontaneous onset of labor. Aseptic abortion, either spontaneous or due from surgery. And then what we always are asking our patients about that are female and in severe abdominal pain, being able to recognize and think along the pathway of an ectopic pregnancy. And then is there any RH or ABO sensitivity as far as the infusion of blood or even mom's interaction in the fetal circulatory system with that sensitivity causing complications. Transport. We all hope that delivery control is done in the nice controlled environment of a hospital, especially in the presence of complications. I know one of your first days you talked about EMTALA and different laws and rules related to transport. Don't let a facility get you rushed, get you in a world of hurt with them and trying to just get a patient out the door, being in a hurry, frantic themselves often with a either unstable crashing OB patient or one with imminent delivery. Remember, they are required to treat patients, including those in active labor, and make sure that they're either stabilized or safe to be transferred without imminent delivery, or that they take the time, manage the delivery, and then transfer two rather than one patient. And as we see then, once delivery is complete, you have two patients that must be addressed as well as family. Because at that point, most of the time, every mom, dad, aunt, uncle, brother, sister, and 35 friends that's found out have shown up. And you'll have to follow your agency's rules about how you deal with that or how you address that. We are somewhat selective in who we allow to ride with us. Obviously, nobody ever rides in the back. One person up front that's got to be some close relative and adult age. And that's still then at our discretion, but you'll have 50 people wanting to ride and follow and everything else. So just like talking about yesterday with trauma, yes, remember to deal with your family, remember to address them, let them know what's going on, that kind of thing. But you also have to plan ahead to be on the same page of what will be allowed and what will not be allowed, and be pretty clear in relaying that to them, hopefully as tactfully as possible. For the transport or additional units needed to transfer both patients, most units can't transfer to, and you'll see in a minute what we use to transfer our pediatric patients. So we cannot transfer mom and child at the same time. It's not only against our policy and doesn't fit within our truck, it's also unsafe, despite the fact that, you know, you have some nurses that think, oh, just let them hold the child. Like, what are you thinking? Would you put somebody in a car and do that? But there is such a push with that mom-child initial skin-to-skin contact that many of your staff that work inside a facility forget aspects of safety to look at, oh, they need that skin-to-skin contact right now. And yeah, that's great, but we also have to be able to safely transfer them to the location that they need to go. So looking at, again, do you need additional units? Do you need different stretchers or equipment? And ours are different, so we have to go either by the base and change out equipment, or have another team deliver that to us. And then our additional team members needed, depending upon what the situation is. If we're transferring and there's not a specialty pediatric team available in the area, we may consider either taking a pediatric respiratory therapist or a neonatologist or a nurse practitioner or somebody with us to accompany along the transfer. And again, that additional equipment. So for us, here is one of the first things we use, probably one of the neatest contraptions that's come out in years, and that's called the baby pod. Looks like a nice little capsule for the child. It will hold up to, I think the manufacturer says 25 pounds now, but usually once anywhere near that size, we're putting the child in the regular PD-mate seat. But for an infant that's term and not the neonate size and doesn't maybe need all of the interventions provided by an isolate, this works well for us. It's a portable device. When it's not in use, it fits into a duffel bag type case, so we can carry it to another team in the truck without completely changing stretchers. We can carry it with us in the truck if we're going on a pediatric transport and unsure, just in case we need it. And the child goes into the capsule. It closes the clear plastic over, and you see there, you can open the plastic if you need to, cover completely, or there's the small portals there that you can reach through to access the child and treat and manage lines or probes or whatever needs to be done during the transport. You have a good view of them. There's little place for the child to go. Even in an accident, they're completely contained. They have Velcro straps that go across them, and then the bottom of it actually for new deliveries that need the help controlling warmth. There's the chemical heating pad that you snap just like a hot pack, and you can put it up under the patient to provide that warmth. So you see it at the bottom. Also, the handles near the head there serve to hold IV pumps if needed. But you see it on its own at the bottom, and then you see it strapped to a stretcher. This one, obviously, being a stretcher for a helicopter, but you get the idea of it. It attaches the same way to a normal EMS stretcher, but pretty unique and well-designed method for transfer. Other one we use for those that are more neonate range is our isolette. This is a picture of our actual isolette with the capability to have the pumps, the plexiglass container across the top for the child with lamps for us to work with and, get a good view of the patient. It has a built-in heater that heats the capsule along with temperature monitoring probes. The cardiac monitor as well as the vent here is built into it, and it is actually mounted then onto a stretcher base, which makes it a little more cumbersome to use and doesn't give as flexible an option because you're either taking isolette or you're taking a regular stretcher. You can't kind of take this as you would the baby pod just in case. You're going to have to take one or the other. And this actually will work with the Stryker lift system we use and makes getting this monstrosity in and out of the truck much better. But that is the pediatric isolette that we would utilize for more of the neonate range up to, just deliver. Again, that does come with often some difficult interaction with staff as they fuss back and forth about the skin-to-skin contact and just throw the newborn on mom and seatbelt them in together and transfer them. No, that doesn't work. They either have to be a isolate, a baby pod, or a PD-made seat. One of ours became so militant that the staff member finally looked at it and said, well, we've tried for about 15 minutes to get mom in that little box and she just won't fold up that far. So at the point you're transferring now a neonate or newborn and have to look toward resuscitation, I'm going to give you a shameless plug here for NRP. If that's something you're going to be engaged in, then you need to take the course. It's online modules you complete and then come in for a skills check-off one evening, which conveniently there's an opportunity for that next week. And there's no way to cover neonatal resuscitation within the couple hours we have to cover special populations. So it is an excellent course. It has some excellent online simulation. And then Pre-Med does have a really good instructor to come in and do your skills check. A preview of the course and how you'll see it different is the algorithm here, and you see how things change considerably when you switch to the neonate world. Everything is based off 30-second intervals, so although we continue the idea of under 60 for a heart rate, we provide compressions, we transition to initially trying to let the child take its first breaths, start its heart rate and increase it on its own. And it becomes difficult for those of us that are used to jumping right in to realize, okay, I've got to wait 30 seconds, open the airway, see if the child does anything, give them a chance. At the 30-second mark, begin positive pressure ventilations, give it another 30 seconds after we've opened and suctioned airway and begin positive pressure ventilations until we get to the minute and 30-second mark before we ever begin chest compressions, even though this entire minute and 30 seconds, we may have only had a heartbeat of 40. So it's a completely different change in mindset. And then when you look to after a minute and 30 seconds, going to 2 minutes before you would even consider an intubation. And then 30 seconds after that before you would start looking to umbilical lines and consider an epi. So having to get adjusted to that difference in flow and how the patient's addressed takes some time, and those online simulations are great for that. It almost becomes like the challenge of a video game. I enjoy playing them every time I do it, just to see how the score goes for me. And then if it's not bad enough, to try to change our thinking on how we try to resuscitate the infant, realizing how different their body is operating as they transition environments from the environment being within mom to now out in, world environment. And you see the green color box to the right, the preductal SpO2 targets. And, we're all used to seeing SpO2s at 90 to 99 and having to adjust our mindset there to expect that at a minute, their SpO2 should only be 60 to 65, at 2 minutes, 65 to 70. We're not wanting to throw oxygen at these neonates. High flow oxygen ends up causing harm, resulting in a lot of eye injuries. And so letting them slowly climb, because it's 5 minutes before you should even expect them to hit an 85% O2 sat. Yet, most of us would be panicked if they weren't 90 by minute 2, had we, not known or followed an NRP algorithm. So that's kind of a quick overview. You see the algorithm there. If nothing else, you can find the quick reference cards to have with you of the algorithm online. You can find short synopsis of NRP and recent updates online, but if you do nothing else but print off and have those and review them, but my suggestion is to enroll in a NRP course that are conveniently offered by Pre-Med. Did I mention they're conveniently offered by Pre-Med next week?
I think I heard that.
I think you heard that, okay. So, as children age, they pass that neonate range, PALS guidelines will take over. You haven't updated those. Again, Pre-Med has PD Trio courses coming up. But you're going to have to consider their interactions based upon their level of development. Remember how our child psychology comes into play. We've covered that in various courses, from PALS to our initial paramedic training to PEP and PDITLS courses, and how, the development of the child and what their thought processes are, what their fears are as they age. And we should be keeping that in mind as we address them as a patient. Not going to treat a 6-month-old the same as you're going to treat a 9-year-old. You have to remember to get on their mental level, and then consider, are they a child of, I won't say normal, because that's become, kind of a politically incorrect term to say, normal child, but more the expected development, or are they a special needs child that has some level of mental or physical handicap, or something that has placed them at a level different than what you would normally plan to address that 8, 9, 10-year-old at, are they an 8-year-old more with the functioning of a 5 or 6-year-old? If so, you're going to address based off their mental age versus their physical. And then again, plan for the interaction with family. They're going to be often stressed, worried. There may be family dynamics going on there that you get brought into the middle of, but know ahead of time what your plan to deal with them is, what your policies are as far as who can ride, who can't ride, where they can ride. Nothing turns out worse than one crew member saying one thing and then one crew member going back and telling them something else. Make sure before you approach that you're all on the same page of what's allowed and what's not allowed. So that is our high-risk OB and PEDS. We're at just after 11 o'clock. Going to be about the right time, I think, to wrap up between 11:30, 11:45. Give y'all just over an hour for lunch before you're back to listen to toxicology with Brandy. So we're going to switch to geriatric now. And this is much shorter than OB and PEDS because there's not as many considerations there. It's just more how you manage and address the patient. We all know the disease processes and things that we encounter. So transport of the geriatric critical care patient. Need for transport. The geriatric population, while prone to certain conditions, they advance in age, they have various medical conditions, comorbidities. Though they're present and though they're there, they often come in with a need for transfer similar to our medical and trauma states found in younger adult patients. Quite simply, they need the transfer to a higher level of care for whatever their illness or injury is. They need the cardiac specialist. They need the respiratory specialist. They've been involved in a trauma and need a trauma or a neurotrauma consult. So it's the same reasons for transfer. It's the same management of medical conditions. You've just got to consider a little bit differently things that they may not be able to as easily manage as our adult or younger adult patients are able to do, such as comorbidities, a disability, lack of reserve. Their skin's often thinner, easier to be subjected to a skin tear, more easily dehydrated, less able to manage temperature, things along that line that we'll see more of a list here. And so we're always trying to make things better or manage them at the same level, not make things worse. And keeping these differences in the geriatric patient in mind is what will help us prevent making the condition worse while we get them to what they need. So with the assessment, got a picture here of an iceberg, and you see there what's on top and what's under the water. Just a little bit on top versus everything hidden with the size of the iceberg under the water level of the ocean. So it's very similar in thought then to how we would assess the geriatric patient. We have what we see and what we come in to talk to the patient about, but we don't always, unless we're very thorough, pick up with what's hiding beneath the surface, such as, they're there for a fall, but why did Granny fall? Did Granny fall because she tripped? Did she lose her grip on a walker? Or did she fall because she's had a sinkable episode, and the sinkable episode is coming from a run of DTAC? Did she have a sinkable episode because she's dehydrated? Did she come in, going back to sepsis lecture yesterday, did she come in because she thinks she has a UTI and she's actually, labs come back, she's in a sepsis realm due to elevated lactate and these infections that often they're, oh, it'll go away, I don't want to go yet, I spend too much time in the hospital, the avoidance of wanting to go, sometimes financial considerations, whatever the case may be, that they've delayed care for that UTI. Or are they the one we talked about yesterday that comes in complaining of respiratory distress, and the respiratory distress is due to the imminent respiratory failure resulting from their septic process, and they didn't realize that, the UTIs got out of hand, or a skin infection's got out of hand, or an open diabetic wound has now developed an infection. So with the assessment on a geriatric patient, it really doesn't change, other than we have to keep in mind that it differs from younger adults with the fact that typically, you do the assessment on the younger adult, what you find is what's going on. Yes, we all know paramedic class throws you the scenarios where you respond to an MVC and the MVC has occurred because the guy had a heart attack, and during his heart attack, the workload on his body threw him into a state of hypoglycemia, and all these comorbidities that we're looking to see if this unit will find. But in the younger adult population, that's not the common patient you're presented with. The geriatric patient is the opposite. That is the common patient you're presented with. Is what you get or see initially is the top or the tip there of the iceberg above the waterline, and what's going on or what has been impacted is all beneath that, and parts that you don't see or could be easily missed, easily not picked up on. So you want to be thorough in the assessment, thorough in how you evaluate both the patient and the information you're receiving, the labs, the radiology reports, and areas from the nurse and doctor, and how you compare that and link that with what you're seeing with your patient to be sure that there's not other concerns that may need to be addressed or may need to be taken into consideration before you initiate this transfer, to make sure that the patient does make it to the next facility in the best shape possible. Transport considerations, obviously, as we age, there may be a disability or a mobility issue. They may not be able to jump up from the hospital bed and have a seat on your stretcher. They may have to be assisted to the stretcher. They may have to be slid across to the stretcher. There's different issues there you have to take into account. If you get bedside, they're wanting to go to the restroom before you leave for the 2-hour transport. What kind of assistance to and from the restroom do they need? Are they normally mobile or not? Or Do they use assistive devices, canes, walkers, whatever? And are those devices, a cane, a walker, present with the patient? And are those facility owned, or is that property of the patient that needs to go with them? Be, again, very cautious with disability mobility in that a lot of these people don't want to admit there's a significant issue as there is. So they'll try their best to make it on their own, to be able to ambulate on their own when they know they can or shouldn't. And so be real cautious with getting too far away from them, or how you let them go to a restroom or transition beds or whatever, because you want to prevent any further injury that would come from a fall. And it's almost a competing view there. Their view is, I want to do as much independently as I can possible, and your view should probably be, I don't want you to do any more than you have to because I don't want to risk a fall. And so there's competing outlooks. May also be disability in their sense of vision or hearing. You know, you may have to talk louder, you may have to get in front of them where they can see you more clearly, see your lips moving, that kind of thing, to understand and hear. They may hear better on one side than the other. During transport, have to keep in mind again that, like other patients, newborns, trauma patients, that kind of thing, they have a increased difficulty in regulating temperature. They are easily subjected to skin breakdown, so watch how you position, if necessary, if they're positioned and are going to be up against a rail on the stretcher, or that's their position of comfort that is placing them near a more hard, less padded surface, that take blanket sheets, whatever necessary to pad that area, prevent skin breakdowns. You'll see a lot of your ICUs have the sacral pads that are placed on patients that are going to be in the bed in the ICU for long term. If necessary, you think it's going to help during the transport, you can acquire one of those from the ICU and place it, and it goes right over the buttocks of the patient, but provides some padding there where a lot of the weight goes when they're in the supine position, and will help take some of that pressure off to help prevent decubitus ulcers and skin breakdown. Have to take into consideration sensitivity to medications. It may not take as large a dose as we would normally give medication. With geriatric patients, you might want to start low and work your way up versus giving the maximum dose at one time. And also consider any interaction that may occur with drugs that they are already prescribed for existing conditions. You'll find patients often that have issues with mental status or dementia that you have to manage. Healthcare compliance, you know, they, just like mobility issues, they either don't want to continue getting treatment, they don't want to be on a lot of medications, they think that's worse for them than not taking the meds, and so they are less than compliant always with medical treatment. Sometimes you actually have to talk them into letting you do certain things for them. They have financial concerns about how are they going to continue to afford the care and the hospital stays and the transports. And then they may be a case where they reached a point they're near end of life care and they would rather withhold treatments and, you know, are ready to let more of a nature take its course route than to continue to suffer through treatments that are less than pleasant. And then family dynamics, when you really get into that aspect of end of life or near end of life care, where either the family, in best cases, come to grips with it, but then you have situations that you have to deal with where maybe the family split. One part of the family wants grandma or grandpa to get all the possible care they can and wants them to go through 4 or 5 more additional rounds of treatments or whatever. And then there's another side of the family that supports the patient decision of, no, we're done with the unpleasant treatments. We let nature take its course. And so as a transport team, you may get caught in that interaction because you're the one, transferring them to a higher level of care, and that may not be the route the entire family wants to see this patient taking. Just to highlight from a legal and paperwork aspect, DNRs are still needed in an aspect of critical care transfer. Your hospitals often confuse this, so be very cautious when you are transferring between facilities. You'll often arrive at a hospital and they'll tell you in the report that the patient is a DNR. Make sure you still get the yellow North Carolina DNR form. Looks like this with the stop sign on it that we would always do as a field EMS agency, because unfortunately hospitals and transport are not on the same page. Hospitals will do their own form of a do not resuscitate based off a physician's order that's placed into the chart that's identified on the patient's chart, and that in-facility order does not require this yellow do not resuscitate form. And a lot of your hospital staff does not realize that doesn't transfer outside of their facility doors. They think because it's there in the chart, that's what the patient is going to get, no questions asked. And we have to educate and inform them, know that if they're being transferred, we have to have this yellow form signed by, physician or their alternate advanced practice provider, so that we can honor those wishes between that facility and the next facility, that those hospital orders do nothing for us going down the road in the back of the truck. And it's up to that sending staff. I've had ones that went, got the form, doctor signed it, they sent it with us, continued them as DNR, which was perfectly fine. And I've had others say, well, doctor's not here, we're not doing it, so good luck, just hope they don't code on the way. And, you're placed in that position then to have to go tell the family, well, they didn't do the appropriate paperwork, we're going to transfer, but if something happens en route, they're going to get the full ACLS algorithm. You're going to wind up diverting to the next ER at that next location, and they're going to find their family member now probably with either a King airway or an intubation and 3 rounds of ACLS drugs and shocked and everything else. So taking that moment to, inform the family, hey, if this happens, this is what you're going to find and this is why, because the facility chooses not to do the paperwork or doesn't realize that there's a significant difference. So don't let them get you in a bind by, well, there's a hospital order here. We still, because it's an EMS truck, it's under regulation by OEMS, we need a DNR. Nice yellow form here. or if there's any orders that are more specific and not just the straight DNR, we all know there's most form that lets them spell out the options of what they would like done and what they would not like done. Same with this, hospital has the similar mechanisms for notating this in the chart, but once they hit the back of our truck, leave out those hospital doors, those hospital orders do not apply to us, and we still need this most form. And if I'm correct, we're at perfect timing because it is right at 11:30 as I aim for. So that gives you an hour and a half for lunch, and I think Glenn will have some instructions for you for logging back in at 1 to listen to toxicology.
So actually what I need to do is tell Randy to log on.
So she can log on, switch the host
She's
to
gonna
her.
log on, we're gonna give her the host.
Okay, so it's now lunchtime, be back at 1 to listen to her. I'm gonna go ahead and mute here and we'll just do the process of transitioning the host to her. If
Tell me the code.
you drop off, you've got the code to log back in at 1 o'clock, or you'll hear her unmute at 1.
I'm here. Good morning.
Hey. So we're gonna pass the code on over to, pass the host over to you.
All right.
And then when you're ready at 1 o'clock, just get it going.
All right.
Host just changed to you. You've got it, and I'm about to log off.
All right. Have a good one, Corey.
Randy,
Okay.
Randy, text me when you're ready so I can log on too.
Okay. Sounds good.
All right, dear.
All right.
Hey,
Thanks,
everybody.
Corey.
Diane, what'd you say?
Thank you, Corey.
No problem. Thank y'all. I will be back in the next week with y'all as you wrap up.
All right, Glenn, I'm going to pause the recording for lunchtime.
Perfect.
All right, peeps, we have started recording again into the cloud. I don't think Glenn is here yet. And we may be a couple behind, but I'm going to try to get started on time today. So if you're there, just say hey. If not,
Hello.
hey. Hey, Rob, how are you?
I am well, thank you very much.
Lovely. Sperano, are you there, or did you just stay logged in? I'm thinking he just stayed logged in. But in the interest of not running it over into all dayness, we're going to go ahead and get started. Oh, there's Lynn. Hey, hey.
Hello.
Hello, hello. All right, well, we're going to get through this material. I'll give you guys a 10-minute break sometime in the middle to stretch your legs, do some yoga, that kind of stuff. And of course, if you need breaks, please take them. I apologize for any noise you guys may hear in the background. And we'll figure everything out along the way. So we are doing toxicology this afternoon. I am Brandy Serig. I'm a nationally registered critical care paramedic. I got my undergraduate degree at East Carolina University in health and safety management. So I focus on health, safety, and exposures. My master's research was in toxicology, environmental toxicology of inhalants. That was also at East Carolina University in conjunction with the Brody School of Medicine and the Department of Environmental Health. Thank you, honey. I appreciate you. So we're going to focus on toxicology in the critical care interfacility setting today. And we're going to go through just a few things, okay? So we're going to look at tox emergencies. Make sure you have enough information to protect yourself and your crews, okay? Proper assessment and care of these patients, and of course, stability, treat, management of toxicological emergencies, okay? So when we talk about scene management, it's one of the most critical things, even in the critical care or interfacility setting. So you, of course, have two managements. You're going to have actually arriving to the scene because you have to realize that your critical care vehicles are actually integrated into the emergency care plans for all these counties. So any large scale events, all your critical care trucks become 911 trucks. Additionally, you can have the transfers from smaller facilities into larger facilities, right? And so both of these are going to be chief considerations when you're going in. And I always tell people I never trust somebody else's decon that I didn't witness myself. So you're going to go to a lot of these facilities and not be able to see what's going on and not be able to really see what was actually done to your patient. So the first thing you need to really protect is going to be yourself and your partner. A lot of these situations you're going to get into are going to have a risk of you bringing home something that you don't necessarily want to. Okay. You're going to need to ask a lot of questions about what exactly these patients were exposed to, and the method of exposure is going to be very important. So, toxicological substances, can be introduced into the body in any way. And the method of induction is going to be very critical to how you actually manage your own safety. Okay. So available resources, if you want to snap a picture of this, this is going to be real helpful. So state of North Carolina requires that you have the hazmat ID manual in your ambulances. They should be usually in the driver's door. The current version that is released is orange in color. And I tell people, I say, I have big hands. So I always tell people it's the palm-sized book that sits in your truck that you have never touched in your life. I guarantee it. That'll have all your vehicle signs for your 18-wheelers, your heavy trucks, and also your train cars on it. If you need more information, MSDS is material safety data sheets. These are vastly available online. Okay, so bust out your FirstNet enabled cell phone, and go ahead and give it a quick Google, just MSDS sheet and the chemical or substance that you need more information on. The MSDS sheet will give you basic toxicology information on your chemicals, safe handling. It will tell you what kind of gloves to use, keeping in mind that most services stock a basic nitrile glove on the truck and that's it. But actually some of the chemicals that you can be exposed to in a hazmat situation will actually eat directly through a nitrile glove. I also remind people that if you're allergic to latex, we've got one doc that is, and the best thing she ever told me is she puts 2 layers of nitrile gloves on before she has to put her surgical latex gloves on. So nothing says that a latex glove can't be your outer glove. If you are allergic to latex, just remember not to touch yourself. Because latex is a contact allergy. The best way I've seen is the doctors actually hold both hands together to prevent them from touching anywhere else on their body incidentally. There's the number for Chemtrack. They're a great chemical resource, and they'll be able to get you anything else. And of course, the Poison Control Center. Additionally, the state EM office can contact any of the regional hazmat teams in the state of North Carolina. So if you're in the Eastern region, your on-call team is going to be out of Williamston, and that's Williamston Fire Department in Martin County. They are the regional hazmat resource. They are the kitty litter scoopers for most large incidents around here. And there also are glowworms if we actually get anything large and legitimate. Okay. So remember, toxic agents are found everywhere. Okay. If you have never read the MSDS sheet on your ink toner, it is absolutely 100% not something you want to swallow. So you're going to find things in your homes, in your schools, in the large agricultural and farming communities we have here, specialized industry, transportation, and anything outside can also be an exposure. Okay. Most accidents come from carelessness and improper handling. So if you're going to handle a chemical, please go ahead and research the chemical before you actually hold it. And then, of course, we have people who are intentionally abusing, or intentionally trying to harm themselves. Okay. The critical care professionals are trying to, let me see if I can shrink this. This is like 4:1. There we go. Okay. Critical care transporters can improve outcomes by addressing problems before they happen. So the safety and health of the transport team is always going to be your high-risk priority. Please take care of yourself first. Remember, people are unnecessarily violent, even with healthcare providers. And that patients may not be properly decontaminated, and they can expose you to toxins as well. So basic care, airway, breathing, circulation. Okay, so patent airway, okay, support the respiratory effort and promote effective respiration. So make sure your patient is properly decontaminated. And we're going to try to prevent additional absorption of the toxin. And then we're going to go ahead and provide antidotes when appropriate, or dilutions when appropriate. Okay. We're going to try to enhance elimination and make sure that it's properly eliminated out of the body safely, and make your patient comfortable, because this process will not be great. Okay. So use personal protective equipment prior to exposure to your patient. So before you're getting a report, before you're next to this patient, you should know exactly what they've been exposed to, how much, if they know how much they've been exposed to, because the dose always makes the poison. and go from there and make good judgment calls about what PPE you're actually going to adorn to your patients. Okay. So you need to make sure you should assess what PPE they need by dispatch. And you're going to encounter lots of hazards before you get on this scene. Okay. So your flight communications team and your dispatchers are actually going to be critical in determining your knowledge prior to arrival to your patient. Okay. That's going to allow you in the air ambulance or in your ground ambulance to actually retrieve additional things like proper gloves. If nitrile gloves aren't advised, you need to make sure that you're going to have that PPE available. Additionally, you need to make sure that you're parking in appropriate locations so that you don't track some of these lovely substances back to your home base with you, because nobody wants that sitting in the bottom of the bay. And then you'll have to call the cat litter team again, and then we'll be in a lovely mess all over again. Okay. So you want to protect your patients by protecting yourselves. There's nothing more useless than an injured provider. So standard of suit. Make sure you're using the level of PPE that's appropriate. If you're getting into A and B, they should have been deconned before you got to them, and you're likely in a hot zone with other contaminants. Okay. D is always advised. You guys, I know a lot of people don't like the flight suits, but having an additional flight suit available lets you peel the flight suit off and leave your underclothing on. So my go-to was always to have a pair of gym shorts and a tank top on under my flight suit, okay, so that anytime that happens, I can peel my flight suit off, hose my boots off, and I am clean, and the flight suit can be discarded without walking around without clothes on. Okay. A and B, you're going to be in the hot zone, and you really, as a medical provider, want to avoid that when possible. Okay. So any smoke, vapors, unusual odors, signs, markings can tell you that you're in an unsafe event, or you possibly are about to have an exposure if you haven't already. Using your cue cards to know what toxic substances are carried where, and being familiar with your local industries, the manufacturing, the agricultural, and any lab facilities you have. You need to know exactly what is in your district, what's in your response area, and what you can be facing. So I live in Pitt County, North Carolina. I live in the city of Greenville. And we can hear the trains go by about 2 or 3 times a day. And they are going to and from PCS Phosphate and Aurora. So a lot of the time we are getting highly hazardous phosphate materials that have been strip mined out of Aurora, and they pass right through on the train tracks. And they're all clearly marked. And then, of course, the materials that they use to actually assist with the strip mine, the acids and things like that, also travel by rail car to there. And so we're faced a lot of the times with a possible train derailment that could involve a lot of these chemicals. Okay, so kind of getting familiar with exactly what goes through your area, and where it's going and why, and knowing the basic chemicals in those manufacturing processes can sometimes help you prepare. Additionally, when I'm working in Fountain, we have a very large rock quarry next door, and they use a different set of chemicals, and we're very prepared with the binding agents for those chemicals in order to safely get patients out and get ourselves safe rapidly. Okay. Remember, patients can be hazards too. Okay. Please be safe. violent, bizarre, or aggressive behaviors. Excited deliriums can be common with patients with toxicological emergencies. Okay. Please use your scene safety protocols, your law enforcement resources when necessary, and don't go near anything that is not secured and ready for you yet. Okay. Any significant illness or psychiatric illness, a history of violent behaviors. If you work a 911 system, then you're going to know which of these patients are because you'll see them frequently enough. Any altered patients or confused mental status, those patients may not even understand that you are a paramedic or a healthcare provider. Okay. And any illicit drugs, medications, okay. Anything that's going to mess with their head is going to be an indicator for violence. And then, of course, you have the patients which are fine and then become violent later, including during transport. Okay. Of course, do a full airway assessment prior to taking on these patients, okay? Especially with corrosive inhalants, those patients are going to need aggressive airway management prior to transport, as that's not something you really want to be doing while you're going down the road. Okay. And just because they're awake, alert, and oriented right that second does not mean that they're going to be able to maintain that depending on what they're exposed to. And all vapors can actually bind with the water and saline in your airway and cause further damage. Okay. Continuously evaluating airways to make sure they stay patent. Okay. We don't give syrup of Ipecac anymore, but some hospitals do still administer it. And activated charcoal via NG can be given in many cases, especially in some of these smaller regional hospitals. Okay. And just remember, any vomiting can comprise the airway. So make sure you're proactively managing these toxicological emergencies with an antiemetic when appropriate. Oxygenation. Metabolic needs change vastly after a toxicological stressor. So the metabolism post-exposure to avoid some of these medications actually increase in order to increase elimination of them. It's one of the body's compensating processes. So when that happens, you need to know that sometimes you'll have an increased demand for oxygenation, despite the fact that the patient is not having any respiratory true difficulty. These are responses to things like the acidosis, increased metabolism, and the body's natural compensation towards dilution of toxic substances. Okay. Remember, some things that you inhale can affect the gas exchange pathway. They can damage lung tissue. Okay. They can prevent alveoli exchange. They can cause V-Q mismatch. All of these are common dysfunctions. Okay. So there are asphyxiates, which literally suffocate somebody from the inside. They block oxygen and carbon dioxide exchange at the alveoli. You have your organophosphates, which are common farming chemicals, and they cause sludge, which is a massive, massive, massive liquid loss to the body. And then, of course, your neuromuscular blockers can be paralytics and can interfere with the body's exchange. Okay. So indirect toxins, anything that's sedative. Okay. So your opiates, your benzoids, your TCAs, which are your Elavils, ethanol, are going to just reduce your drive to breathe, but not interfere with the chemical processes of actual exchange. Okay. Hypoxia can occur from a variety of complications from these agents. Okay. They can displace the oxygen. They can interfere with the cellular metabolism, okay? Or they can increase pulmonary edema. Hey, Glenn. Respiratory compromise can come from trauma, burns, or aspiration. Okay. Evaluation of circulation is more about perfusion in these cases and not distal circulation as we would normally be worried about. So we're looking for signs of VQ mismatch in these patients, and we're looking for actual end organ tissue perfusion. So depending on the agent that you're dealing with, you want to make sure that any agent that's going to affect your kidneys, that they're properly perfusing enough so that they can metabolize and excrete these things rapidly. Okay. And just realizing that these agents can actually interfere and damage the perfusion systems that actually lead to metabolism and excretion. Okay. Of course, your baseline health before an exposure is paramount to your surviving an exposure. This goes for providers as well as patients. This is one of like my preachy moments in which I tell everybody, if you're not healthy now, you should probably get there. Because if you have an impaired cardiovascular system, an impaired renal system, an impaired liver, your chances of survival post-exposure decrease rapidly because your organs were not functioning at 100% prior to the exposure. So post-exposure, you're going to be even lower than that. Okay. These mechanisms will impair your cardiovascular function, which will cause VQ mismatch with your respiratory system. They can further damage your renal system and put you into renal failure. You can get liver cirrhosis from some agents, and they can actually impede the process of your entire liver. And not all things that you're exposed to actually metabolize out of the body. So there are certain chemicals and things that when exposed to, you're going to have a long-term retention of in the body. And so the healthier you are to begin with, the more capable your body is of actually eliminating and reducing that content and as effectively as metabolites are exposed in the body. So decline in patient status can come from a lot of things, okay? How much they were actually exposed to, had their fluid volume or loss, okay? Any electrolyte disturbances that the chemical may cause, any airway or respiratory compromise, pre-existing diseases, including cardiovascular resistance diseases, anything that's going to alter that. Of course, the dose, and in a lot of exposures, UV and sun exposure, post-exposure, or temperature management actually can increase or decrease the metabolism based on the substance, okay? So make sure you're doing proper temperature management with these patients too. We don't want them too hot. We don't want them too cold, okay? And those are actually going to have a direct effect. Also, some of these agents are UV reactive. And when you get those rare agents that are UV reactive, what you end up happening is a further exposure that's going to result in further damage from UV that makes them more sensitive. Okay. Make sure you get a full assessment. This is, basic EMS. You have to do a full assessment. And then you need to weigh your options as to whether antidote treatment on scene is more appropriate or whether treatment and further assessment in a regional facility is going to be more appropriate. Okay. Make sure you get this little bit of information. I don't know who else has toxicologists in the emergency department. I know Vidant here does actually have a toxicology department as part of the emergency department. UNC does as part of their children's hospital, but I don't believe they have it as part of their adult facility. And then I know Charlotte does. So make sure you're actually getting good information. So what you actually need to know is exactly what substance. Okay. If you can take a picture of the labeled substance for the physician at the hospital, that'll help them actually narrow it down. As the labels tend to change when they change productions, and certain chemicals formularies actually change over time. So the Comet we use in our toilet right now is not the same Comet that our grandmothers used in the toilet 20 years ago. Those substances that make up that powder have changed. And if you have a 10-year-old, cleaning substance under your sink, you want to make sure that we're actually treating you for the appropriate thing. Okay. Time, quantity, and duration. So about what time the event occurred, how much they were actually exposed to it, and how long. Okay. This will help them determine the how close they are to an LD50, which is a lethal dose of 50% of the population, and expected symptomology based on how much in their dose of exposure. You need to know route because metabolites differ based on your route of exposure. Your body metabolizes things completely differently with a different metabolite depending on the route in which it's exposed to. Okay. Of course, their initial clinical status and their course of treatment thus far, and any decon and treatment that they've actually received. Okay. You need to look at whether it was accidental or intentional. Remember, anybody willing to hurt themselves is definitely willing to hurt you. How many patients you actually have, okay? And any other hazards. So when you're dealing with multiple patients, one of the things that we see quite frequently is that people are dealing with multiple patients and a shortage of antidotes. So you need to make sure that your most vulnerable patients are actually being treated with antidotes and reversals before other patients, and really doing a good triage of all those patients to make sure that you're giving the medications to the ones who need it the most quickly. Okay. And just because you're doing an interfacility transport, please make sure that you're still talking to family members and field providers. Get a copy of their PCR or ACR, whatever you guys call it, before you transport to see how things actually looked on scene to the responding medics. Okay. So pre-existing conditions. Okay. So make sure you're looking. Pre-existing medical conditions can really affect the metabolites that are coming out of a chemical exposure. Okay, so if you have a patient that is a renal failure dialysis patient who's had a renal toxic exposure, they're actually not going to be as affected as a healthy patient that's exposed to something renal toxic. They're already in renal failure. Their kidneys are already pretty much toast, versus somebody healthy who is actually going to experience a very severe reaction to those kinds of things. Okay. Long-term versus short-term exposures are very important in intentional overdoses. We have plenty of psychiatric patients that get refills on their medications and try to take them all at one time. And remember that your psychiatrics and substance abuse patients will need follow-up treatment. Okay. So some commonly associated vital signs with their associated overdose agents. Okay. So tachycardia, meth, or amphetamines. Amphetamines being the prescribed version, methamphetamines being the cooked version. Okay. Caffeine, yes, caffeine, you can overdose on caffeine. I do promise you it is a possibility. If you're striving for that, keep going. It takes a while. Cocaine, atropine, TCAs, and antihistamines. Okay. Tachycardia, of course, with carbon monoxide, cyanide, and any various medications that you're going to see prescribed that are going to increase heart rate. Okay. Slowing of the heart rate, okay, are going to be your benzodiazepines, your clonopines, alcohol, toxic substances, right? Okay. So your digitalis, your organophosphates, okay, your calcium channel blockers. Of course, your TCAs are a sedative. I don't know why they don't market them as that as much, but Elavil is a sedative. It's prescribed and told people to actually take it while sleeping. Okay. Hypertension, okay, and hypotension, depending on the medication, are also concurrent signs. And can be, okay. And then, of course, high body temperature, okay. Also, when using high body temperature as a way to try to figure out exactly what substance they're on, remember that excited delirium syndrome can happen without any drugs in their system. So that is absolutely a possibility. So those are definitely considerations to take into account. Okay. Also thinking about hypothermia, low body temperature, okay. Ethanol, you'll see people get the shakes a lot. Any depressants, okay. Any vasodilators or sedatives will likely give you hypothermia. And you'll see these patients kind of with a soft tremor. Okay. Laboratory testing, okay. These patients should have a full tox screen, okay? While you're doing a full medical assessment, you should also be sending off for a full tox screen. Acetaminophen are common. Salicylate levels, your electrolytes, acid bases, ethanol concentrations, and any other likely exposures that they've had, okay? And remember, a full urine screen is possible, okay? And so we're going to talk about toxidromes, okay? So toxidromes are regular patterns of symptoms, okay, for known drug exposures, okay? So we'll start with anticholinergic syndrome, okay? That's going to follow exposures to antihistamines, atropines, benzotropines, and jimison weed, which is, well, it's a recreational substance. So you're going to get tachycardia, hyperthermia, dilated pupils, and warm, hot, dry skin. Okay, so these are your Benadryl overdoses, okay, your atropine overdoses, okay. So lack of intestinal motility, so there's constipation, delirium, you'll have seizures, psychosis, and urinary retention. Okay. And urinary retention is painful because you feel full, but you're unable to actually void your bladder. The delirium is very, very graphic in these patients. And if you've ever taken too much Benadryl, try to go to sleep, people tell you they wake up and they have really weird dreams, and that's the touch of the delirium and the psychosis coming in. And it dries you, it would dry you up in such a fashion that you would not urinate properly. Okay. So going into cholinergic system, that follows organophosphate poisoning. Okay. And it's going to be the exact opposite of what we just saw. Okay. Depending on the receptor used. Okay. So you can get tachycardia, hypertension, fasciculation is I call it meth twitchy. So you've seen those patients that are just a little twitchy. That's what we're talking about with the fasciculation. Weakness, very high blood sugar, and dilated pupils. So with these patients, that's going to be your nicotinic receptor toxicity. Okay. Your muscarinic receptor toxicity is going to be your sludge patients. Okay. So anything liquid in your body will come out. Okay. We are talking about excessive salivation. Okay. Sweating and tearing of the eye, excessive urination, diarrhea, gastroenteritis, emesis, and meiosis. There will not be a dry spot on this person, and it will not stop despite large doses, okay, of fluids and everything else. Okay, these patients are just going to lose every bit of fluid that they possibly have within their bodies. Okay. And then, of course, you have the muscarinic toxic, okay, which is the diaphoresis, the sweating, the diarrhea, the urination, the meiosis in the eyes, okay. Bradycardia, bronchospasm, and bronchorrhea are also very common. Emesis and salivation with lacrimation, okay. These patients are going to have it coming out of everywhere and look like the worst gastrointestinal disease that you could possibly have. But it's going to be a chemical exposure versus an actual treatment. Okay. So, but both end up with altered mental status, severe coma, okay, and seizure activity. So you're going to have a patient with full sludge and seizure activity. So those patients are going to be at really high risk for actual airway compromise. Okay. They've got vomiting, emesis, diarrhea. Okay. They've got bronchial constriction and everything else. Okay. And while they're having all this going on, they're going to go into a grand mal seizure in front of you. Both of these things together are going to lead to airway collapse and compromise. Okay. So long before you get there, make sure you're controlling these patients. Okay. And treating them as aggressively as possible, and making sure that you are, in fact, starting with the basics, treating their airway, making sure their airway stays patent, dropping that NG tube and emptying their gastrointestinal system as well as you're able to. Okay. Opioids. I have not met a paramedic in the state of North Carolina that hasn't treated an opioid overdose on just about every single shift. It has become an epidemic. It's one of the North Carolina public health initiatives. And I believe everybody's administration is very active in reducing opioids. I don't know if anybody else is working with their sheriff's office, but we did training with our sheriff's office here in Pitt County, and all of our deputies actually carry the 4 milligram Narcan nasal sprays on all of their vehicles. They actually carry 2 of them at a time, one for themselves and one for a patient. And additionally, if you go out to Greensboro, they have a clean needle exchange program. Several counties in North Carolina actually have a post-overdose protocol where they're actually taking these patients to detox centers to actually get treatment instead of being in the emergency department. So look out for all these kinds of programs in your area. And if you need resources to help locate so you can start one in your area, let me know. So illicit use is the most common form right now, especially here, but accidental ingestion and adverse reaction can also happen. Accidental ingestion of opioids is very common in our young pediatric patients, kindergarten and younger. Anything that can crawl and babble can grab a pill and swallow it, I promise. So that can be your morphine, recreational heroin, recreational fentanyl, or prescribed fentanyl, okay? Remember, morphine and fentanyl do go home with patients in certain situations, and those oral medications can be accessed by people who are not prescribed that medication. So you're going to have lethargy. These patients are going to be highly sedative. Okay, we're going to have hypoventilation. Okay, up through apnea and full respiratory arrest. Okay, non-cardiac pulmonary edema. Some will have pinpoint pupils. Depending on the version of carfentanil, not all of them are getting pinpoint pupils anymore. Okay. And full out cardiac arrest, because once you have respiratory arrest, you can very easily progress into cardiac arrest. The sympathomimetic syndromes, okay. Amphetamines, cocaine, caffeine, ecstasy, okay. Your patient is going to look like they just came from a rave. Congratulations. They're going to be overstimulated, sweaty, excited, slightly delirious. They can go into seizures and eventually have a syncopal or a comatose event. Okay, they're going to be hypothermic. Okay, they get sweaty. They're easily agitated. So use your calm, happy medic voice, not your aggressive, abrasive medic voice with these patients, because agitation can commonly in these patients actually go ahead and excel into a violent behavior pattern. So hypothermia, this is what people who do not know what they are doing do to patients sometimes. Okay, so this is post-sucks, okay, or inhaled anesthetic agents, which can be just your basic laughing gas. It depends. These are genetically susceptible patients, okay? So despite the current political climate, you need to ask your patients what their race and ethnicity is. Especially if you live in the I-95 corridor or I-74 corridor. That patient population is riddled with Lumbee Indians, and you need to be very prepared to treat some of these patients very differently. Muscle spasm, muscle rigidity, acidosis, okay? Hypothermia, tachycardia, tachypnea, okay? You'll see changes in urine output, rhabdomyolysis, hyperkalemia are all possible. These patients need an ICU bed for an extended period of time. Okay. So neuroleptic malignant syndrome is from antipsychotic and schizophrenic medications. Okay. So new onset schizophrenic patients or psychotic patients or patients that recently underwent a medication change are at high risk for this. This is why psychiatrists prefer to start antipsychotic medications in the inpatient setting and titrate them while you're inpatient. So you're going to have hyperthermia. They're going to be sweaty, muscle rigidity. You'll see metabolic acidosis. So make sure you're using your end-tidal monitoring, okay? And severe confusion in these patients, okay? They'll get renal failure, respiratory failures, arrhythmias are common, and full-out cardiovascular collapse are common. These patients need intermediate level monitoring until they're complete and go back down to psych for a medication change and better medication choice. Okay. So serotonin syndrome, I've seen this one up close about 3 or 4 times now. So these serotonin SSRI drugs, which are your Prozac, your Zoloft, most of your common antidepressants right now are SSRIs. They're the preferred antidepressant and anti-anxiety medication from PCPs. Okay. These can also happen if you are, if you've ever been to a, what do they call them now? Skittles parties where everybody takes a bottle of pills, they put them in a bowl and everybody just takes a handful of them. That happens with these as well. Okay. Paxil. Demerol is not on the market anymore because of this and a bunch of other reasons because Demerol is a terrible medication. Amphetamines, TCAs, okay, which are your Elavils and lithium. Okay, so you're going to have irritability, muscle rigidity, hypothermia. With the hyperthermia, they're going to be sweaty and feel cold. Okay, the muscle rigidity, lack of flexibility in the joints, massive diaphoresis, headache, tremors that can escalate into seizures. This can cause coma, increased heart rate, all sorts of tachyarrhythmias, hallucinations, and it will end up post-coma into cardiac arrest. Okay. Yes, serotonin is that important. These symptoms occur in 2 patterns, okay? With too much of an SSRI, this can happen, okay? Additionally, when patients are not weaned off an SSRI medication, these same set of symptoms can happen. And it's called serotonin uptake withdrawal syndrome, okay? So be very careful in your patients who say, I couldn't get my medication refilled, and they have any of these symptoms and they were on an SSRI. Remind them that SSRIs are very, very cheap and GoodRx can get them for you for about $10 a month. But you need to make sure that they were not on an SSRI medication. If they were, you need to go ahead and pre-treat them, especially if they are headed toward a seizure. You need to go ahead and prepare like this patient will seize because they most likely will. Okay, I'm going to give you guys 10 minutes to take a break real quick. And then we're going to finish this up for a little bit, okay? Trying to see who's here. Yay. All right, so take 10 minutes and we'll be right back. All right, I hope everybody was able to get a little bit of a stretch and a break while you were listening. Okay, and we're gonna move on to skin decon. This should usually be done before you get to your patients, okay? You want to use proper PPE when doing this. And it's most effective right after an exposure. Otherwise, they've pretty much trailed it behind them the entire way. Remember, things that react with water are not good, especially if you're trying to spray things off. Removing and bagging clothing is critical. Dry powders get brushed, not rinsed. Contaminated areas can be flushed, okay? And do not neutralize things while in contact with the body. Some things require treatment beyond massive irrigation. Some things require calcium. Other things, alcohol. Please look up what you're dealing with first before you decide to decontaminate it on the body. So ocular decontamination is actually necessary when dealing with the eyes. The eyes are just one of those lovely weird organs in the body. The cornea is very sensitive to hydrocarbons and corrosion. And remember to keep flushing eyes with water. Here is the device they typically use in the emergency department to flush eyes. It's hollow tubing, and then it gets put on just like a contact lens would. Yes, please make sure you remove any contact lenses if a patient has an ocular exposure, because those substances in the contact lens can actually break down and cause more damage or adhere to the eye. Gastric decontamination is necessary. Okay. Oral gastric lavage can happen, usually while they're inpatient. Okay. So anything in the stomach that hasn't been absorbed yet can be removed if it's not absorbed by activated charcoal. Okay. It's not always effective, so we don't use it as the only form of treatment. These patients have to be alert, okay? And with it, they need to know what's going on because we do not want them to aspirate. Okay. And this procedure can actually cause the opposite effect of what we want by increasing the gastric motility in this area and actually for pushing things further into the GI tract faster. We don't do this if it's not that bad of a toxin. So some toxins the body can deal with and push out, okay? If you don't have a clear time as to when the ingestion actually occurred, or if there's a reasonable antidote available, or if your patient can't protect their own airway. There's the NG and the OG tubes that are available. And take note that the second patient is a pediatric patient, because this happens in kids more than anything, is getting something in their system. Okay. Emesis by syrup of Ipecac. Not done nearly ever. When I was young, this was something that everybody kept in the medicine cabinet in case your kids ate or put something in their mouth that they weren't supposed to and it made you puke it up. That is not done vastly anymore at all, and I have not seen syrup of Ipecac in a store in a very long time. But they still do list it as an option available, so that if you see your child put something in their mouth, it is possible to immediately induce vomiting with syrup of Ipecac. and prevent any absorption within the GI system. Okay. We don't do this if they're sedated, if they're not with it. Okay. Anybody with a history of seizures, because the last thing you want is somebody having a seizure and vomiting. Or anybody who has anything corrosive in their system. Okay, those are going to be big, firm no's. Okay, so activated charcoal, we do through NG and OG tubes. Okay, and that helps prevent aspiration. And if in basic class a millennia ago they made you lick activated charcoal, you know it tastes absolutely horrid. I don't know how we got patients to chug it through a straw. But it does work with a good amount of medications that can be within the system, okay? So if it's a substance that can be absorbed by charcoal, and if they did take it orally, then gastric decontamination can be a great methodology. Okay. If they are sedated and they do not have a firm airway in place, this is not the thing to do. Anything caustic or hydrocarbon are, of course, not going to be anything to bring back up the system, but let go out the other end of the system. Okay. And charcoal will not bind anything on the left side of the periodic table. So lithium, iron, heavy metals, okay, or alcohols, okay, because it uses a water-based system to actually bind those things up. Okay, and you can do more than one dose of activated charcoal, okay. Making sure that you've talked to a toxicologist, either at the North Carolina Poison Control Office or your local regional toxicologist. So if it is not absorbed by charcoal, you can do whole bowel irrigation, which is saline based, okay? And you use it on anything on the left side of the periodic table, metals. So iron, lithium, potassium, any heavy metals, okay? Or enteric coated medications. Okay, you can also increase elimination of the medication. Okay, which you want to do with patients with pre-existing conditions or anything that's heavily concentrated. You can do that with multi-dose activated charcoal. Urinary manipulation, which is going to be increasing the rate of urination. You can do that with peritoneal dialysis, hemodialysis, okay? And any sort of renal replacement therapies. Okay. Illegal drugs. So these are all things that we commonly see. Okay. So acetaminophen is the most commonly overdosed medication. Depending on what they have taken with it, the most common age demographic that overdoses on acetaminophen is age 15 to 19, and it is primarily females in the US. Okay. Usually these are attempted suicide calls, and these are usually young women, and Tylenol is just readily available in the home, and that was their convenient medication of choice. You can treat these with activated charcoal to bind them up, and these patients are going to end up on the transplant list untreated, okay, because it is in most household bottled doses, including those at Sam's Club. If you take a single dose, it will not be lethal. It will, in fact, just damage your innards beyond repair. Amphetamines are both therapeutic and illegal. You're going to have to treat these with sedation usually via benzodiazepine. Valium tends to work better than Versed. Don't ask me why, just my clinical experience. But the Valium seems to work better. And of course, activated charcoal if there's still some in the gut. And you can have stimulant washout system, which is where there's too much stimulants and then you're going to have a rebound effect. Death from benzodiazepines is rare unless combined with another substance. So what happens is the benzodiazepine will be sedative and the other medication will come in and actually kill the patient. So beta-adrenergic blocking agents, you're going to treat with gastric lavage, activated charcoal, dialysis, and possibly glucagon. Calcium channel blockers, okay, get IV calcium and gastric lavage or activated charcoal. Things that are used for heart rate control, you will administer an antidote for. Make sure you're testing to see exactly which version of these medications that you've actually gotten. Hyperkalemia, okay. Arrhythmias and renal diseases are fifth. Cocaine is rapidly absorbed by all mucous membranes. Okay, it's commonly smuggled inside the body. Okay, there is no antidote available. So remember, this is why people will rub it on their gums, why people snort cocaine, because it introduces it to the mucosa in the nasal passageways. Okay, this can go on any mucous membrane in the body and be active. Opioids we see every day, but just remember that some of these patients are actually regular medically managed opioids patients, and that rapidly withdrawing them from opioids can do more harm than good in some of these patients. Remember, naloxone is for respiratory failure, and not to wake your patients up. So, salicylates, okay. So when you have tachypnea, which is rapid respiratory rate, and tinnitus, which is ringing in the ears, is when we do this. And the treatment for this almost exclusively is going to be hemodialysis, and that's going to help save your renal system. And the earlier you do that hemodialysis, the better. SSRIs are your antidepressants, anti-anxiety medications. Activated charcoal is common for this medication since they're typically an oral medication. Okay, they can be bound with activated charcoal and then treated afterwards. And don't forget to be constantly treating your symptoms, especially your seizures. Okay. Any toxic alcohols, okay? So toxic alcohols get treated with ethanol as a competitively binding agent, okay? So the way to avoid methanol exposure is to actually get them drunk with large amounts of ethanol. And so that'll competitively bind with the receptors and they'll improve from there. TCAs, tricyclic antidepressants, are treated with Elavil. So antidepressants are commonly overdosed in suicidal patients. Make sure you're giving activated charcoal. Okay. This is your one pill killer list, which means one pill of a standard dose will kill an average child. Okay. So what happens in these patients is you're going to have a syncopal event, a seizure event, or anything else. I know we go to a lot of pediatric seizures, and the first thing we think of is, are they having a febrile seizure? The first thing you probably should think about is, are they having a toxicological emergency? Has this child been exposed to something? Were the parents and caregivers paying enough attention to see? Are they in the walking, crawling, grab and put things in their face stage? Those things are very overlooked in the pre-hospital setting, but very focused on in the emergency department setting. Okay. So your sulfonylureas are going to be your glycerides, and those actually stimulate insulin production within the body. And so what you'll have is a severely hypoglycemic child that's had a medication exposure. Opioids, of course, are going to cause respiratory depression, and respiratory failure leads directly into cardiac arrest for children. Any topical salicylates, okay. Lindate is a medication for scabies and lice. So what will happen a lot of times with that medication is that an older child in the home will have gotten lice at school, and mom and dad left the lice treatment sitting next to in the shower room. And the smaller child went into the bathroom and played with it, put it in its mouth. Any iron preparations, iron tablets, can't be avoided out of a child's system. Clonidine is one of the anxiety medications. I've seen camphor a couple of times in children, and it was actual topical camphor that ended up being the cause of the exposure. Ages ago, it came in a little green tub, and older guys like to use it as a hand cream for joint pain and arthritis. And of course, benzocaine, okay, Visine, Afrin. Little kids see them, they look like bottles, and they will latch onto them and drink them. And of course, calcium channel blockers, beta blockers, heart medications, and antidepressants, any pill you would drop on the floor, incidentally. So I always remind it is overdose season right now because the kids are home from school. And in a lot of rural eastern North Carolina, when the kids are home from school over the summer, the grandparents end up taking care of the children so the parents can work. And sometimes grandma drops a pill out of those Sunday through Saturday pill packs that she's got set up, and won't even realize that she's dropped one because she pops the cup open, she puts it in her other hand, and then down the hatch they go. And it's very easy to mishandle your medications like that. I always remind them that the pharmacy will do a pill pack instead of putting them in those little containers. So chemical agents are common, okay? Hydrofluoric acid, hydrogen fluoride, okay, cyanide, chlorine, ammonia, okay, carbon monoxides, all chemical agents that you can be exposed to, okay? So acetylcholinesterase are going to be your pesticides and possibly your chemical weapons, okay? These were used some by the other side, I believe, during the first Gulf War. So tachycardia, hypertension, weakness, paralysis, okay? Soap and water, okay? It seems so simple, but after any exposure or treating one of these patients, make sure you go back to base, take your clothes off, put them through the wash, take yourself, put yourself through the shower, wash your hair, wash under your nails, make sure you wash everything really good, and, you know, take a shower like you're in Mexico, no water in the mouth. So gastric lavage, activated charcoal, okay? Your atropine and proloxamine auto-injectors are going to be your antidotes. So blister agents, pulmonary agents, and incapacitating agents can all be aerosolized. and cause severe damage. So your blister agents, if you see in the picture of the children on the Arabian Peninsula that were all blistered up after a chemical attack, that's one of the blister agents. Pulmonary agents will cause, you'll just see people dropping and coughing and expectorating, okay? And some of these agents can actually cause syncope, paralysis, and other things. So carbon monoxide, okay? Indoor appliances, fires, or intentional exposures from automobile exhaust. So we've had, I think, 2 suicides in our county from this. You sit in the garage, you seal it up, and they take from the tailpipe into the window and commit suicide by carbon monoxide. And these patients are also from any enclosed space fires. They will have headache, nausea, vomiting, abdominal pain, and dizziness before they have seizure, coma, dysrhythmia, chest pain, ischemia, and then death. Make sure that these places have been ventilated before you go in. Usually the easiest way is to open the door, open the windows, give it 5 minutes, and then go in. So caustics and corrosives, okay? If it burns going down, it should go down the other end, okay? As far as ingestion goes, okay? But these can also cause caustic reactions on the skin and in the airways. This can cause necrosis, acidosis, and then, of course, alkali or basic substances cause liquefaction necrosis. So instead of burning, bubbling, and clotting, it actually liquefies the tissue and gives you a margin that way. It's more extensive kind of tissue damage. Make sure you use your material safety data sheet. Okay. Do not induce vomiting with any corrosive materials. Okay. And do not attempt to neutralize them because you have no way of knowing what the pH of the initial substance was to know exactly what you need to correct it with. Okay. Chlorine, ammonia, and any other asphyxiating gases. You're going to tear, cough, drool. You'll have difficulty breathing and positioning the airway. You can have tachypnea or full-out apnea. Upper airway and lower airway symptoms are possible. You'll need oxygen. Bronchodilators need to be given away from the exposure site. And make sure you're humidifying the oxygen and assisting ventilations as needed. But make sure when you give a bronchodilator that the air around the patient is actually clean, or else you're driving the damage further into the patient. Cyanide and cyanide poisoning kits are most common in industrial settings. And there are some chemical weapons that still use cyanide as a tool. Okay. And they look like guppy fish is the best description I tell people. It's like a fish out of water, like they're just trying to suck down for air. So they have respiratory depression, but they're also desperately trying to get on top of air. They need to be deconned, okay? And you do need a cyano kit, okay? They are commercially available, and this is what they look like. They're wonderful, and they keep everything, including your drip sets, intact. Okay. So your hydrocarbons, okay, widely used, usually following an oral ingestion, and your typical GI symptoms following an oral ingestion. Okay. Any local or skin will cause, irritation and burns and common skin symptoms. If it's viscous, it will not have a great effect on the patient. And and there is no antidote for hydrocarbons. Hydrogen fluoride is lethal in very small quantities, very small quantities. It will give you common GI symptoms, pain, and tissue necrosis at the introduction site. You would give calcium for these because calcium would be able to bind up the fluoride. Okay. So remember that it's never typically a single chemical that's going to be released. And depending on the weather, things can change. Okay. So here are little glowworms cleaning up a spill. Okay. Stay out of the hot and warm zones and treat your patients back. Okay. That's going to keep you clean in order to actually transport and get your patient to definitive care. Okay. And remember, the very first responders may also need treatment and care on scene. Okay. Typically how they set these up, we want to be in the cold zone, taking the patients out and away from the hazard. Okay. You do need to consider your destination carefully when choosing it. And we're going to assess the risk of bringing the hazmat container to the hospital. My hospital would freak out. So we try not to do that. So make sure that you've talked to somebody at the hospital. Usually pictures are better than the actual containers. Okay, if we want to take it off the patient before we bring them to the hospital, we don't want to bring any of it with us. Okay. Radiation emergencies. So you need to be wearing a counter, and you guys should have a formal radiation response plan. If you haven't read your county's emergency response plan, your radiological response is actually included in that. Okay. Radiation decon is similar to any other decon. Okay. Removing everything, washing with soap and water, and then going through. Okay. Radiation can be inhaled, so providers should be wearing respirators. Okay. Patients will die within several hours after a large radiation exposure. And your treatment's going to focus on removing accessible radioactives from the body and then providing supportive care to your patient. Anytime you transport a patient, please make sure they're clean before you put them in your rig. Your rig is your home or your office, however you happen to see it for the day. Okay. And it should be maintained and clean. Okay. Does anybody have any questions today?
No, ma'am.
Woohoo! All right. So I will tell you my one case study for today, and you guys can run with it, and then we'll get out of here. Okay. So you have a 5-month-old infant with respiratory depression that has gone into respiratory arrest. Okay. And your crew has provided supportive care for the patient. You've intubated the patient. You placed the 5-month-old on the vent, and you've gotten your lab report from your transferring facility. And it indicates that your child is positive for opiates. Okay. What is going to be your standard course of care, and what was the likely exposure route for your patient?
Exposure route was probably unintended digestion by finding it or picking it up, possibly like mom's pills or something like that. That's what I would think.
Okay.
And what was the first part of the question?
And what's going to be your care for this child?
Really, it's going to be, I would say, respiratory care, just making sure that they're oxygenated and ventilated appropriately, and just checking neuro status. I would say in my care, I'm not going to do Narcan if I'm able to just continue to maintain the patient with the ventilator, because I don't want them to wake up at least on me. Or at least enough to increase the respiratory rate.
Okay.
But they're on the ventilator, so that I can control.
Yeah. So a lot of providers jump to the use of Narcan in this patient, and you want to remember that your younger patients are most susceptible to detoxing off of these exposures. And so if you give Narcan to this kind of patient, what you're going to have is a status epilepticus event. And they're going to be actually harder to manage. My patient that I actually had been exposed, mom was on pain management for chronic opioids. And mom was actively breastfeeding her 5-month-old.
Yeah, interesting.
And it just got to the point where the child cumulatively, I guess mom had taken a rescue dose of her medication. And I don't know how in pain management the topic of breastfeeding never came up, but it did not. And so with small children, remembering that they can get exposures from anything, and even things that you wouldn't necessarily normally consider for them, is quite possible. So just remember your pediatric patients, making sure their food source and making sure where they were at the time of exposure is very valuable information to keep in mind with some of these complex patients. And so mom got a social work referral and a prescription for formula. And her child actually had to be weaned over, I believe, 2 to 3 weeks in the pediatric intensive care unit, because it had actually had a long-term opioid exposure over pregnancy, and then through the first 5 months of gestation. So that is all I have for you guys today. It is Friday. It is 2:30. The message I have in my inbox from Glenn reads, look for Socrative Quiz 2 to arrive in your email inboxes over the weekend. Please get that completed by Monday, and we look forward to seeing you again then. Okay, does anybody have any questions before we close it out for the day?
No, ma'am.
All right, happy Friday, guys. I hope y'all have a good weekend.
Thank you.
Thank you.
Thank you so much.
Thanks.